This week also saw the publication of the long-awaited CAS review, which looked at how the NHS treated children with gender identity issues. I'm joined now by the journalist Hannah Barnes to discuss what we learned. So Hannah, perhaps you can begin by reminding us what the Tavistock Clinic was and why Hilary Cass was commissioned to do this review.
So the Tavistock Clinic, the Gender Identity Development Service actually didn't start at the Tavistock Clinic. It started at St George's Hospital in South London as a tiny little unit in 1989, and then it moved to the Tavistock in 1994. And originally it was based at the Portman Clinic and then moved to the Tavistock Centre as part of the wider Tavistock and Portman NHS Foundation Trust. And it was really very, very small in the first, at least decade really. The first year in 1989, it only had 4 referrals, and it was a service that was designed to help and listen to a very, very small number of children who experienced this intense distress about a mismatch, what they perceived to be a mismatch between their biological sex and their gender identity, how they felt about themselves. And really for many years, it was, I guess, what we might call now a safe space. You know, it was a place to talk. It was talking therapies largely. At some point in the 1990s, what we now call puberty blockers were available, but only at the age of 16. So they weren't so much really to block someone's puberty. It was more a precursor to moving on to hormones, to cross-sex hormones. But really, it wasn't that common. And by the time someone had got to that point, mostly they had a lot of talking with the professionals at the service. So it was always designed to help that young person navigate through life, really, and with their families. And in the early days, there was a lot of kind of outreach work with schools just to try to help them how to manage these children in distress. Then it all changed, really, as we went into the new millennium, and a new medical pathway was designed by a team in the Netherlands. And they argued that, again, for a very small number of children who had experienced this extreme distress since early childhood and for whom that had persisted into puberty, they suggested that they could be treated by a puberty blocker, so a drug that acted on the pituitary gland that stopped the release of our sex hormones during puberty. And the idea was that if a young person was in really severe distress, by pausing the development of the body in a way that's going to make it more aligned with your biological sex, that would relieve some of that distress and give the young person time to think. That was only ever a hypothesis, and it transpires that it's not really borne out by the evidence. But the idea was that you did that. If the cross-gender identity persisted, then hormones could be available at around the age of 16. So that would be testosterone to help masculinize the body for girls and estrogen to help feminize for boys, followed by, in the early years at least in the Netherlands, genital and or breast surgery. And there was lots of pressure on GIDS at the Tavistock to make this available as well. And in the Netherlands, it was available from the age of 12. And as we went through the 2000s, this pressure grew. And it wasn't just from groups who represented gender questioning children and adults. It really came from those in the medical community as well, who said, look, there appears to be this treatment that's going to help this group of distressed children. Why are you withholding it? So in 2011, the GIDS team, along with endocrinologists at University College London Hospitals, embarked on a research study because they said, look, this does look promising, but we really don't have very much data. We've only got, 70 kids in the Netherlands. That's not really good enough, and it's very early days. So they embarked on their own research project, and they enrolled 44 children aged between 12 and 15 to try to look at the impact that blocking puberty at those younger ages would have. And this is really where the story becomes quite extraordinary. because having embarked on research, which is a good thing to do, albeit the study wasn't designed very well, they then really completely abandoned that approach. And in 2014, despite the fact that they had no data at all to support this, they were allowed by NHS England to roll out the routine prescription of puberty blockers at these younger ages. And in fact, they did away with a lower age limit altogether, and provided a child had reached the early stages of puberty, they could potentially be eligible for the blocker. And they then went even further and rolled out blockers to those for whom would never have been eligible under these Dutch criteria. So the pathway was only designed for those who had had intense distress from early childhood, who had a stable home life, who didn't have any other major mental health difficulties. Yet the GIDS team rolled this out to teenagers who had only started experiencing distress in adolescence, to children with quite severe mental health difficulties, some with psychiatric disorders, and to those who really had quite chaotic living arrangements. So there was a massive, massive departure, even from the existing weak evidence base. And when data came back from those first 44 children, bearing in mind they had already rolled it out to several hundred of others, that data didn't replicate what the Dutch had found. In fact, it showed that these children weren't benefiting from the puberty blocker. And in fact, some seemed to be deteriorating in terms of their well-being. And confronted with that data, nothing changed. They continued to prescribe in the way that they had been. Well, forgive me, they didn't actually prescribe. They referred on to endocrinologists at other hospitals, at UCLH and at Leeds General Infirmary, but effectively nothing changed. And this is really where some of the staff working at the service became very, very concerned.
You've interviewed dozens of clinicians at the Tavistock. I mean, was there anything in Hilary Cass's report that really surprised you in terms of anything new in particular, or was it just the extent of the failings that were going on?
No, nothing surprised me in it, sadly. Well, not sadly. I'm glad nothing surprised me. But I think still seeing it all together in such a calm but forceful, categorical way was quite powerful. And it actually made me just feel both sad that it's taken so long, because we've known this for such a long time, and also quite angry, I suppose, that it's been ignored for so long. I think the thing that I did find shocking was not surrounding GIDS, actually, not surrounding the Tavistock, but surrounding the conduct of the adult gender clinics, which refused to help conduct research into this group of people that could help them make better healthcare decisions in the future. I mean, that baffled me, although it seems now that NHS England is going to compel those clinics to comply. So, but that did shock me.
And I mean, one also argument in being involved is that, you know, the private health clinics as well. I mean, we've discussed a lot about the NHS England, for instance. How do you see the future of sort of those private health clinics and what they're recommending in terms of this changing in future?
Well, I know that there are various efforts to try and restrict the private clinics as well. I think it's baffling. I mean, it was put to me several times in other interviews. I was given quotes from the head of one particular gender clinic saying, well, we've gone backwards and we can't wait for evidence for another 10 years. And I do find that argument quite baffling, because really it's been an abject failure by gender clinics around the world to conduct proper research into these drugs. And that's why we are where we are. I mean, had GIDS undertaken proper research at the time and actually followed up the patients and looked at it properly, we might not have been here. But no decent research has been conducted. So that's why there's no certainty over the evidence base. But I find it quite baffling how one can make that argument, that you'd advocate for a drug which is potentially life-changing for children and young people without a robust evidence base. We just don't do that in other areas of medicine. And I think that's been the problem the whole way, that this has been overlooked, because one clinician described it as the word gender being some kind of magical cloak that once it's mentioned, everybody sort of turns the other way. And it's not been treated like any other area of the NHS. And that's been the problem. And to hear the private sector still advocating for the same approach, which has been roundly rejected, found to be unsafe, is quite surprising.
Just as a final question then, Hannah, I just want to ask you, because you said in your answer there about evidence around the world. I mean, presumably other countries as well are seeing a kind of surge in these kind of cases, and they presumably must be having their kind of different pushback and different sort of debates going on within their health services about the need to kind of get evidence-based policymaking in the future. Can you give a bit of context to the international element of all of this?
Yeah, I mean, exactly the same thing is happening in gender clinics across the Western world. I think we've seen a real split now, though, between Europe and North America and Australia. So in Europe, we have the Scandinavian countries, so Sweden and Finland in particular, their health authorities have also undertaken these systematic evidence reviews of both puberty blockers and cross-sex hormones. And they've come to the same conclusion as both Dr. Cass and the National Institute for Health and Care Excellence, NICE, that it's not strong enough. And so they have both, as have Norway, turned to an approach whereby medication is last line of resort, and there are strict conditions attached to that. They're slightly different in different countries, but a growing number of European countries are moving towards caution. I mean, that is absolutely the direction of travel, not towards a more affirmative approach. In the US, we have something completely different, where even clinicians who themselves are trans and have helped children transition, but who say it's not right for everyone and we should be more cautious, they're attacked. It is extraordinary. It's toxic here, but it is far more toxic over there. Similarly, in Australia, although they've had their first whistleblower, if you like, it's a much more affirmative model. They're not quite, they're very far behind a number of European countries on kind of the discussions around the evidence base. So we have this divergence. Interestingly, one of the many systematic reviews that's fed into Dr. Cass's final report was about the various different guidelines for care that exist internationally. And her review team have found that actually they're all very weak. The only ones that were sort of acceptable were Finland and Sweden came out on top. But WPATH, the World Professional Association for Transgender Healthcare, none of them are a strong basis for safe and effective clinical care for this group of people, was what they found.
Hannah Barnes, thank you very much for joining us today.
Thanks so much for having me.